With a review of the basic concepts under our belts, let's move on to illustrate clinical examples. In this module, we apply the principles described in the first module to scenarios clinicians face on a regular basis. In each segment, we review relevant recommendations from national and/or international guidelines for the diagnosis and management of common infections. We also demonstrate opportunities for antimicrobial stewardship interventions within these scenarios in order to support clinicians in using antimicrobials more wisely. We will elaborate on these interventions when we describe the essential functions of a formal stewardship program in Module 3. You may also decide to incorporate some of the segments in the second module in your institution's educational efforts.
Acute bacterial skin and soft tissue infections, abbreviated SSTIs, are commonly encountered in the outpatient setting. Understanding the nuances of these infections will ensure appropriate therapy and antimicrobial management. Guidelines for the management of SSTIs were updated in 2014 to simplify the management algorithm for SSTI and also to account for increased prevalence of methicillin-resistant Staphylococcus aureus, abbreviated MRSA, as a causative agent of community-onset infections. In the management of SSTIs, the first critical decision node requires the clinician to identify an infection as non-purulent or purulent, as these descriptive clinical categories denote different likely etiologies and different therapeutic approaches. Necrotizing infections, cellulitis and erysipelas, a type of cellulitis that is characterized by the presence of a well-defined and often red border, are counted among the non-purulent SSTIs. The category of purulent SSTIs includes furuncles, carbuncles, and abscesses. Following the determination of purulent versus non-purulent, the clinician must categorize the infection as severe, moderate, or mild, with these designations dictating appropriate clinical therapy. Mild, non-purulent SSTIs, which are often encountered in the outpatient setting, can be treated with oral antibiotics. Beta-hemolytic streptococci account for the majority of infections and therefore dictate which agents can be used for empiric coverage. As a consequence, most outpatients with non-purulent cellulitis or erysipelas can be treated with an orally administered penicillin or cephalosporin, or, if penicillin allergic, clindamycin can be used as an alternative. While it is generally believed that trimethoprim sulfamethoxazole lacks activity against beta-hemolytic streptococci, recent evidence suggests that this may be incorrect. A clinical trial comparing clindamycin to trimethoprim sulfamethoxazole for the management of mild skin infections did not show any difference in cure rates between these two medications. The use of rifampin, either as a single agent or in combination, is not recommended. The recommended duration of therapy is 5 days, although discontinuation of therapy is ultimately dictated by the clinical response. Patients identified as having a moderate non-purulent SSTI may require intravenous antibiotics, and again, penicillins or cephalosporins provide excellent coverage. An infection is categorized as moderate in contrast to simple if the patient has a typical cellulitis accompanied by systemic signs of infection, which may include a temperature greater than 38 degrees Celsius, a heart rate greater than 90 beats per minute, a respiratory rate greater than 24 breaths per minute, and an abnormal white blood cell count, either elevated, greater than 12,000, or depressed, less than 400 cells per microliter. Recurrent episodes of cellulitis should prompt investigation for predisposing conditions in the affected area, including edema, obesity, eczema, venous insufficiency, and other co-infections, for example, tinea pedis. Prophylaxis may be considered for patients experiencing 3 to 4 episodes per year despite mitigation efforts. Any patient diagnosed with a severe non-purulent cellulitis requires emergent inpatient evaluation and management with surgical debridement to define the extent of infection and empiric antimicrobial therapy to stop the spread. In such cases, broad-spectrum empiric therapy is necessary, including anti-MRSA gram-positive coverage and anti-Pseudomonal gram-negative plus anaerobic coverage. Cultures should be sent from any surgical exploration to determine primary etiology, monomicrobial versus polymicrobial, which will ultimately dictate targeted therapy. The primary treatment for any level of purulent SSTI is incision and drainage. If lumps, bumps, or pus are present, the infection is most likely due to Staph aureus and, at least in the U.S., is most likely to be resistant to beta-lactams. The primary treatment of a cutaneous abscess is incision and drainage, with antibiotics often being unnecessary. Certain criteria merit the addition of antimicrobial therapy following I&D, including severe or extensive disease, for example involving multiple sites of infection, signs and symptoms of systemic illness, impaired host defenses, extremes of age, lack of clinical improvement following incision and drainage. This may occur, for example, in abscesses in difficult-to-drain areas, for example, the face, hands, or genitalia. Patients with moderate disease may be managed with oral antibiotics following I&D. Options for empiric coverage include trimethoprim sulfamethoxazole and doxycycline. These choices can be modified to match culture and sensitivity data from the I&D specimen. Empiric options for severe infections include the parenteral agents vancomycin, daptomycin, linezolid, telavancin, and ceftaroline, among others. These options can be de-escalated to appropriate parenteral MSSA coverage if culture results allow. Cost may be an important consideration for your institution and should be considered on a case-by-case basis depending on individual pharmacy contracts. In general, older agents for which a generic is available are typically cheaper and may offer a comparable spectrum of coverage to other brand name agents. Immunocompromised patients with skin and soft tissue infections are almost always classified as severe, owing to their underlying immune defects. It should also be noted that these patients may have skin infections from unusual organisms, and the clinician should maintain a high level of suspicion for these, including fungi.
Hi, my name is Ann Liu. I'm jointly appointed through Allergy, Immunology, and Infectious Diseases, and it's my pleasure today to speak to you about antibiotic allergies. Antibiotic allergies are a common reason for giving patients second or third-line antibiotics and for administration of antibiotics that are more expensive and unnecessarily broad in spectrum for the patient's infection. Being labeled with a penicillin allergy has been shown to be associated with longer hospitalizations and increased rates of serious drug-resistant infections, as well as delays in resolution of infection symptoms. The American Board of Internal Medicine has recommended against overuse of non-beta-lactam antibiotics in patients who carry a history of beta-lactam allergy without appropriate evaluation of that allergy. Evaluation of antibiotic allergies and drug allergies in general requires a detailed history. If assessing current risk based on a prior reaction, these following elements should be elicited. Knowing the source of information, whether the patient's parents, or a physician who observed the reaction, is important. Next, a timeline is essential in reaction classification, including start and end of possibly related medications, onset and evolution of the reaction, and timing in response to any treatments attempted. A detailed description of the reaction should be elicited, including any skin manifestations and their duration. Knowing what concurrent illnesses were present at the time of the purported reaction, such as a viral infection with an amoxicillin-related rash, also contributes to sorting out the likelihood of a true allergy. Data from the time of a reaction and any provocation testing afterwards, including labs, histology, skin biopsies, skin testing, challenges, test dosing, and desensitization can also inform your assessment of whether the patient had a true immunologically mediated hypersensitivity reaction versus a side effect, intolerance, or other type of reaction. Eliciting whether the patient has had any subsequent accidental exposures can also be very helpful retrospective knowledge. If you are assessing an ongoing reaction, similar elements are needed, but it can be more accurate as the information is more readily available and verifiable. A reaction timeline, reaction description, diagnostic workup, and concurrent illnesses and medications can also be corroborated by an examination and skin inspection. Rashes are part of many antibiotic reactions, and characterizing them accurately is hugely helpful in risk stratification for future administration. Many patients will call any sort of itchy rash hives, but there are many types of drug rashes that are not hives. An immediate onset urticarial eruption with angioedema should be viewed differently from a mild maculopapular rash that gradually resolved without any medical attention, although both may be labeled in the chart as hives. To allergists, hives are urticaria, which implies a specific immunologic pathway distinct from a maculopapular rash, a bullous eruption such as Stevens-Johnson or a toxic epidermal necrolysis, serum sickness, fixed drug eruption, drug reaction with eosinophilia and systemic symptoms, and many, many others. An accurate classification has substantial implications for whether and how to re-challenge. A history of DRESS or TEN or SJS is a contraindication to re-challenge with the culprit drug. So why do we want to revisit histories of antibiotic allergies when there can be alternatives? As I mentioned earlier, one of the most pressing reasons is the poor efficacy of alternatives. For example, use of vancomycin for methicillin-susceptible Staph aureus when cefazolin and nafcillin are known to be more effective. Drug resistance can also limit the use of alternatives, both in treating a current infection and future infections. The exposure to a broader than necessary antibiotic may be reflected in future resistance patterns. Intolerances and drug-drug interactions may also limit use of alternatives, such as gastrointestinal side effects with macrolides. Alternatives may also be contraindicated. For example, we cannot use doxycycline for pregnancy-related syphilis. Penicillin must be used. Other factors such as bioavailability, route of administration, as well as cost should be taken into consideration. Although cost is not the first factor in antibiotic choice, it is one of the central concerns in antimicrobial stewardship. Diagnostic testing for antibiotic allergies can be employed for specific scenarios. Tryptase can be measured in the serum and should be drawn if anaphylaxis is suspected, but must be done in a specific time frame. It peaks about 1 hour after the onset of an immediate type hypersensitivity reaction and thereafter declines over several hours, so it's not helpful when checked further out from a reaction. Tryptase is released by mast cells along with other mediators that account for a lot of the symptoms around immediate hypersensitivity reactions, including itching, swelling, urticaria, bronchospasm, and hypotension. For retrospective evaluations, skin testing can be placed and interpreted by an allergist and can be done with several antibiotics, primarily when suspecting or trying to rule out an immediate type hypersensitivity. Recent anaphylaxis, antihistamines, and some other medications may produce false negatives. And negative skin testing must be followed by a confirmatory challenge, either oral or IV, to make any conclusions. Desensitization is a method of administering an antibiotic or any other medication to a patient who is thought to have a high likelihood or a known allergy, particularly an immediate type hypersensitivity. We recommend that a desensitization be done under the supervision of an allergist. The exact protocol depends on the nature of the prior reaction and the acuity of the patient. It is a temporary state that is maintained only as long as the drug is in the system. Redesensitization is required if doses are missed. Subsequent courses must be done by desensitization. And challenges, in contrast, are done in patients who have a low likelihood of a true allergy and are done to demonstrate the absence of an allergy. The protocol also depends on the reaction history and the acuity of the patient. This should be done with caution in specific circumstances. The decision to desensitize or challenge should be based on multiple elements, which may include skin testing. With regard to common antibiotic allergies, penicillin is one of the most common causes of antibiotic reactions, and about 10% of those patients will report a history of penicillin allergy. Of these, about 90% will actually be able to tolerate penicillin. Penicillin skin testing is well validated and is FDA approved and has a negative predictive value of around 95%. Because it is the metabolites of penicillin that elicit most reactions, skin testing is done with PRE-PEN and PEN-G as major and minor determinants, respectively, which test for immediate type hypersensitivities. It is not used to detect delayed type reactions, side effects, and intolerances. In vitro penicillin IgE testing is available, but carries a low negative predictive value, so is inferior to skin testing. Aminopenicillins include amoxicillin and ampicillin. These can produce allergies in patients who are penicillin tolerant. It is mediated by structural side chains rather than the beta-lactam ring. Aminopenicillins can be cross-reactive with cephalosporins with a similar side chain. Most commonly, though, amoxicillin is associated with a high rate of delayed maculopapular rashes, usually in the setting of a concurrent viral infection. Cephalosporins are less likely to cause allergy than penicillins, and when they do cause an immediate type hypersensitivity, it is to the R group side chain. It is reasonable to avoid cephalosporins with similar R groups, but cephalosporins with unrelated side group structures can be given by graded challenge. Skin testing of cephalosporins is not standardized, but can be useful in certain specific settings. Many people have heard of cross-reactivity among beta-lactams, especially between penicillins and cephalosporins. In a patient with a history of penicillin reaction, the likelihood of being able to safely administer a cephalosporin depends on the type of penicillin reaction, results of the penicillin skin testing, and the cephalosporin generation. Sulfonamides rarely cause IgE-mediated reactions and much more commonly cause delayed maculopapular exanthems. Among sulfonamides, there is no specific cross-reactivity between antibiotics and non-antibiotics, such as furosemide. Sulfonamide skin testing should be reserved for select circumstances, and slow oral desensitization to Bactrim is a useful tool for sulfonamide-sensitive patients. Vancomycin most commonly produces red man syndrome caused by nonspecific mast cell activation with histamine release and symptomatically mimics a hypersensitivity reaction. True IgE-mediated hypersensitivity to vancomycin is rare but does happen, so desensitization can be done if necessary. Usually, pre-medication with antihistamines, holding opiates, and reducing the infusion rate to 30 to 50% are sufficient to overcome red man syndrome. Allergy evaluations to delabel antibiotic allergies are a powerful tool for antimicrobial stewardship programs. A number of studies have demonstrated substantial cost savings and increased use of optimal antibiotics from antibiotic allergy evaluations, primarily in patients with a history of penicillin allergy, as well as other beneficial outcomes. Some institutions have decision pathways that empower the treating physician to determine whether to do graded challenge or to consult allergy with positive outcomes. Partnering with allergists trained in these evaluations can remove a lot of the mystery that surrounds antibiotic allergies. I hope this has been helpful, and thank you for your attention.
Urinary tract infections are among the most common bacterial infection encountered in the outpatient setting and in long-term care facilities worldwide. Given this prevalence, optimization of antibiotics for urinary tract infections is a common target for antimicrobial stewardship programs. Cystitis and pyelonephritis are considered complicated when there is an increased risk for failure of therapy as the result of anatomic abnormality, urinary tract obstruction, or infection with a multi-drug resistant pathogen, or the patient is pregnant. Most urinary tract infections in men are considered complicated due to limited penetration of many antimicrobials into prostatic tissue. 1/2 or more of women will develop a urinary tract infection during their lifetime. Given the availability of guidelines, this discussion only deals with uncomplicated infections in women. We discuss catheter-associated urinary tract infections and asymptomatic bacteriuria in our companion course. Urine culture is unnecessary for diagnosis of uncomplicated cystitis in women with compatible symptoms. Greater than 90% of patients who have dysuria and frequency and abnormal urinalysis in the absence of vaginal discharge or irritation have a urinary tract infection. If there are, however, reasons to suspect infection with an antibiotic-resistant uropathogen, such as recent antibiotic exposure, most commonly considered exposure in the preceding 3 months, or international travel that may have exposed the patient to drug-resistant organisms like ESBL producing Enterobacteriaceae, obtaining a urine culture should be considered. Urine cultures should also be obtained in patients with suspected acute pyelonephritis. Follow-up urine cultures for test of cure are not indicated in patients with either acute cystitis or pyelonephritis whose symptoms resolve with antibiotic therapy. As many as 95% of cases of uncomplicated cystitis and pyelonephritis are caused by E. coli, with most of the rest due to other Enterobacteriaceae or, predominantly in sexually active young women, Staphylococcus saprophyticus. The predominance of E. coli means that its local antibiotic susceptibility pattern dictates the optimal choice of empiric antibiotic therapy. This, of course, makes the choice a moving target as antibiotic resistance to widely utilized agents becomes increasingly widespread. In the patient with uncomplicated cystitis, the Infectious Disease Society of America guideline recommends empiric therapy with either nitrofurantoin for 5 days, trimethoprim sulfamethoxazole for 3 days, a single dose of fosfomycin, or pivmecillin, which is not available in the U.S., for 5 days. Trimethoprim sulfamethoxazole should not, however, be prescribed if greater than 20% of uropathogens are locally resistant, or if the patient has received this combination in the previous 3 months. Fluoroquinolones are a second-line choice and should not be used if greater than 10% of local uropathogens are resistant. Beta-lactam antibiotics other than methicillin have a higher rate of failure, and their use dictates closer follow-up. The choice among the recommended antibiotics should be based on local susceptibility data, host factors such as allergies, and cost. Ciprofloxacin, administered orally for 7 days with or without an initial intravenous dose, ceftriaxone, or an aminoglycoside, may be used in empiric therapy of uncomplicated acute pyelonephritis in the outpatient setting. One of the latter two should be used in lieu of ciprofloxacin if greater than 10% of local uropathogens are fluoroquinolone resistant. If the implicated pathogen is known to be susceptible, orally administered trimethoprim sulfamethoxazole may be administered for 7 days with or without an initial intravenous dose of ceftriaxone or an aminoglycoside. Therapy with a beta-lactam is inferior to the other choices and, if used, should probably be administered for 10 to 14 days. Patients may have bacteriuria in the absence of symptoms. With the exception of pregnancy and perhaps a few other circumstances, asymptomatic patients should not be screened for the presence of bacteriuria, and, if detected, they should not receive antibiotic therapy. This is true regardless of the presence or absence of pyuria. Not only is antibiotic therapy in such instances not warranted, recent evidence suggests it may actually be contraindicated. In a study of a large number of asymptomatic young women with recurrent urinary tract infections randomized to receive placebo or antibiotic therapy because of the presence of bacteriuria, the relative risk of recurrence of symptomatic infection was greater than threefold higher in the antibiotic recipients. Likewise, asymptomatic candidiuria should not be treated routinely with antifungal agents. The IDSA candidiasis guidelines suggest that antifungals should only be considered for patients with asymptomatic candidiuria with a high risk of disseminated infection, such as in neutropenic patients, infants weighing less than 1,500 grams, or those undergoing imminent urological manipulation. Of note, this strong recommendation is based on low-level evidence. For those interested in more information on this topic, we discuss catheter-associated urinary tract infections, asymptomatic bacteriuria, and mimics of UTIs in our companion course, available online.